Hello, everyone. Welcome to tonight's webinar with NAA. I'm Wendy Fournier, the board chair of NAA, here tonight with Christine Sigel, our president, and our executive director, Crystal Higgins. And the three of us are going to be going through your chat. If you have any questions for our guests tonight, we'll be taking care of that and sorting through it. But we're going to have a discussion tonight with Dr. John Gaitanis. And Dr. Gaitanis is a pediatric neurologist with extensive clinical, academic, and research experience in epilepsy and neurodevelopmental conditions. Throughout his career, Dr. Gaitanis has served in a variety of clinical and academic leadership roles, including Chief of Pediatric Neurology at Tufts Children's Hospital and as an associate professor of pediatrics at Tufts University School of Medicine. He's also practiced clinically at major children's hospitals, caring for children with complex neurologic and seizure disorders. Dr. Gaitanis is also a faculty member of MAPS, the Medical Academy of Pediatric and Special Needs, where he's helped to develop a fellowship and a program that provides an evidence-based course of study and training for physicians to help them provide the best possible care for their medically complex patients with autism. So welcome, Dr. Gaitanis. We're so happy to have you here with us tonight.
Thanks.
We
It's
really
great.
appreciate your time. It's really good to see you.
Yeah, it's great to see you too. So, I
Thanks
mean,
for
it's probably
joining
worth
us on the road.
probably worth letting people know how long we've known each other. Is that fair to do?
Yeah, okay. We can, yeah, we can definitely share that. We met in 2009. You were very young. And how old were you then? I don't even,
I think I
you
was
were,
12. No, I'm
yeah,
just
you were
kidding.
like 12 and I walked in and I was like, wait a minute, this guy's a kid. He's like a kid. He's so young. And it's just, but I went in there as a typical crazy autism mom and said, "Hi, my daughter has autism and I want to do this, 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 and this. And what do you think about it?" And I showed you some research and you looked at it and you said that you would look at it and you did. And you thought it would be a good idea. And that was the beginning of our relationship. And then I was really sorry that I told anybody about you because I couldn't get an appointment anymore. So
Well, thanks for that. Well, I'm just happy I didn't gaslight you. That's I'm sure that's happened more than a few times.
a lot
Um,
of us autism moms do get gaslit by
yeah.
doctors, but I mean, we don't have to get into my personal story, but I mean, I did have a request that made sense, and it was ended up being a very, very, very helpful for my daughter. But that's why we're here tonight, is we want to talk about co-occurring medical conditions that happen for, our kids with autism. And there's so many of them, but I would love, because you see so many children with autism and you've helped so many families over these years, I'd love to talk to you about the most common co-occurring medical issues that you see in kids with autism. And the reason I want to do this is because autism is still being diagnosed under the DSM. So our kids are being diagnosed with a mental disorder. And nobody's even looking at what could be happening in their body that could be causing the symptoms that we're seeing, whether it's the motor skill issues. And there's a bunch of things that we can get to. But that's really the main point of tonight is what are the most common co-occurring medical issues that you see in your patients with autism and the effective treatments that you use to help them.
Yeah, and can I answer that in a way that's completely different from what you asked?
Of
Would that be
course,
okay?
this
Okay.
is your show.
Yeah, all right. Well, it's your show, really. But it's just like when we first met. I mean, you're the one with the good ideas. All I'm doing is saying, yeah, that sounds good, and I appreciate it. And I should probably open by saying, like any good idea I've ever had, it really generally came from a mom who suggested it. So it wasn't my idea. And so this is really, and just like in MAPS, I mean, I'm on the board of MAPS. We do education for physicians. I didn't invent or come up with any of this, but I'm fully supportive of it because the reality is I've seen it work in my patients. I've seen, this idea of trying to seek greater health for patients really translates to greater development. And that's really the crux of everything. And so
Yeah.
I'll start with that, but I think thinking about this issue of co-occurring conditions, I'm going to start by saying I think we have to just maybe not contextualize it that way, but really think of the fact that autism is a total body condition for many patients. And this is really one of the things that we I think for MAPS trained physicians, we really think of it not as a brain condition, it's a whole body condition. And it's obviously not all, it's hundreds of different diagnoses being lumped together, but
Yeah.
it's important to note that it's not affecting just one organ. And so in a sense, these aren't really co-occurring conditions, they're just different manifestations of what's happening physiologically. So I'll give you like sort of an analogy. Like if someone has a cold, they might have a cough, a fever, and a runny nose. And you wouldn't diagnose them with a cough that's with a co-occurring condition of a fever with a co-occurring runny nose. And you certainly wouldn't send them to the cough doctor and then to the fever doctor and then to the runny nose doctor, none of whom agree with each other. And
Yeah.
each one is writing you a different medication for the symptom, but not for the underlying cause. Does that make sense?
Right. Yeah.
Um, but that's how we do autism, right? That's what the standard medical approach is. You get symptom-based care, and it's going to lead to multiple doctors, each one who specializes in a given symptom, and they're going to treat the symptom, not the underlying cause. And so that's why I don't like to think of them as comorbidities, but I really just like to think of these as these are all manifestations of the same underlying root causes. So really, if you think of like what the MAPS curriculum is, it's a combination of thinking of autism as whole body, but it's also root cause medicine. Those are really the two things that would distinguish it from, what we usually do and what most pediatricians, unfortunately, are trained to do. What I was trained to do in my training. Um, and that's a good point too to make, that is that none of this came from my training. So anything that I do, whether it's in autism or pandas, my training came from, well, you were one of the best moms really to start as my tutor, but it was really a series of moms who did this training. And all I had to do was really like sit back, listen, and take in some ideas, and then research, go back, research it, and then say, okay, this makes a lot of sense. So that's, I think anybody who sees kids and who wants to work in this area, they have to really rethink everything they learned in their training, and realize their training doesn't end the day that you finish your residency or your fellowship. That's not your training. Your real training is happening day to day, moment to moment with every single patient you see. And it's an ever evolving thing. And I'm not finished in that evolution because frankly, like the more I know, the less I know, right? So you start to realize like how every day I mean, that's what makes it great. Like you draw new connections every day. And sometimes the universe pulls together patients that have stories and moments that feed on each other and help you like think of how to help this next guy heal in a better way. Okay, so that was a really long
Well,
segue.
I just want to clarify for people who think that you're a doctor who just has moms come in and tell you what to do for their kids because that's not really how it works. But what I wanted to say was that you're a doctor who listens and I'm sure you've heard the same things over and over again with your patients and their families over the years. But you wouldn't have known, like what I brought to you that day, you wouldn't have known about that because what did you learn in medical school about autism? And like help us understand what mainstream doctors on what they are taught about autism.
Yeah. So my education in autism in medical school was non-existent. There was
Mhm.
no education on autism. We learned a little bit about child development. We learned how to use like a Denver developmental screen in pediatrics, but really there was no training in autism. So we had no knowledge of this. And so I think, and that is, and then I did a pediatrics residency. So to be a child neurologist, you have to do a pediatrics residency and then you do a neurology residency. So going through a pediatrics residency, you would think, well, this is where I should learn about this, but that's not what happened either. We learned about a lot of things, but we didn't really learn about autism at that stage. Not at all. I mean, frankly,
Right.
not at all. Now, pediatric residents now are required to rotate with developmental pediatrics, and so they'll learn this from developmental pediatricians. They're not going to learn it from me though, and I have a different approach, and I think that's important. And then as you get through neurology, in neurology, you're focusing on a lot of different kinds of conditions, but I think that's where you draw more connections because you learn a lot about epilepsy. You learn a lot about neuroimmune conditions, things like autoimmune encephalitis. That was pretty new when I was a resident, but we were starting to recognize that there were some conditions we can treat with immunologic care. You learn about metabolic conditions. I started to see patients with mitochondrial disorders, like significant mitochondrial disorders. And I never forget, like, I mean, I had one girl I took care of with something called May, who I never forget the difficulty of managing that particular mitochondrial disorder in her. And then you kind of see all these very different conditions. You see brain tumors, you name it. So, and then what happens is then you kind of pull what you learned in all those situations. And when you see a kid, say with autism or a kid with PANS who was developing well up into a certain point, and then the like the wheels fell off at a critical juncture, then you can really then begin to think about how does this relate to like what I saw with say multiple sclerosis or acute disseminated encephalomyelitis or autoimmune encephalitis, like any of these kind of conditions where the wheels fall off in those conditions too. And then you start to think, well, geez, my Malos patient, every time she got febrile, like she would regress. Or my autoimmune encephalitis patient has a very similar picture. They just had a flu shot or, a minor infection and boom, they had a regression. Again, it's like, so you start to pull those together. And then what happened, I think, really that was critical in my career was I finished my child neurology training in 2001. And let's think about what was happening in 2001 is we were suddenly seeing kid after kid after kid, really probably for the first time in history, coming in and saying that they had a sudden regression. That, this was a kid who was developing well, maybe a little bit of low tone, maybe speech was a little delayed, but, putting two words together, really social, really interactive, great eye contact. Suddenly, high fever, um, extreme irritability, and then the eye contact was lost, the language was lost, and it wasn't the same kid. And you'd have to think to yourself, well, if you hear that story, the next logical question is, well, what happened at the time when that occurred? That would be a
Mm-hmm.
pretty logical question. A lot of people don't ask that question. I shouldn't laugh. I mean, it's because it's not funny, but it's true. A lot of times you don't see anything about that in the chart, and you don't see any, or nobody's really asked the question. But the truth is that what I was observing at that time is a lot of the histories I was seeing and observing were related often to immunizations. Like, so that was the key event that occurred prior to the regression. But that wasn't the exclusive one because I had a lot of patients too they also had a lot of ear infections. I was noticing like a higher frequency of that in the patients who had this kind of regression. They were on multiple courses of antibiotics, more than
Mm-hmm.
average. I had one patient who went for surgery, well, more than a few. But I can think of one in particular who went for surgery and wasn't the same kid after the surgery. Just the stress of the anesthesia and the surgery and the recovery, something changed neurologically. And so you put those together and you say to yourself, well, there was a physiologic stressor that seemed to lead to a neurodevelopmental regression or decline. And then you think to yourself, well, I just came off of adult neurology, and when I see an adult who has a very sudden loss of neurological function, what do? It's an emergency, right? We get an MRI, we get an EG, we sometimes do a spinal tap. We do every study imaginable until we find the etiology. And once we find the etiology, we treat it. And you would never imagine a 70-year-old walking in, to a doctor's office or an emergency room saying, sure, grandpa was walking, talking, everything was fine until Saturday. And Saturday he had a really high fever. He wasn't himself. And since then, he's not spoken since. And then what would the doctor say? Can you imagine the doctor saying, well, sometimes that happens in 70-year-olds. It just
Yeah.
happens. And
Yeah.
sending you home and say, well,
Mm-hmm.
this happens. We see this, right? So I had come from that adult neurology training and then I come into pediatrics and I'm seeing this every day suddenly, in the early 2000s, all too common occurrence. And you're thinking, why is nobody doing why is nobody doing anything? Right? It
Yeah.
made you crazy at that time. And we did have one, I mean, there are a lot of people that are really innovative, and unfortunately, sometimes other doctors don't listen to other doctors, not just the moms. But and I'll just mention Frank Duffy at that time, who was at Children's Hospital of Boston with me, and he had a very different approach to this because he would do a quantitative EG, a high density EG, and he was finding that a lot of these kids with that sort of regression were not showing evidence of normal language processing. And he would treat those kids with about 6 months of steroids. And I would watch a lot of those kids, and a lot of those kids were actually getting better.
Mm-hmm.
And then I started to pick up some of those kids in my own practice. And you'd hear those stories, and you'd say, wait, maybe this is inflammatory. Maybe this is immunologic. And it kind of makes sense. There was a fever at the start of it. And maybe we're missing an opportunity to treat and help recover kids at that critical stage early on. Because the truth is, when I think back to my actual training, my formal training, the message I was being given is that this just sort of happens in autism.
It's
This
funny,
just
you
happens.
bring up inflammation, and we've had, I've been around for a while in the autism community, and I've had literally hundreds, at least hundreds of parents tell me that their symptoms get better when they are on some kind of an anti-inflammatory like Motrin, ibuprofen. So the inflammation thing comes up very, very frequently with our kids. Why are their symptoms better? Why are they having more speech when they're taking an anti-inflammatory drug, for something else? And it makes sense, right? So can you talk about inflammation in general in our kids and what you see in the population?
Yeah, because I mean, that gets back to your first question about the co-occurring conditions. But let's think about this. In 2007, Vargas did a pathologic study of autism, patients who had died from other causes. And they used that, I mean, it's a very sad opportunity, but they used that as a chance to see what they could find pathologically in the brains. And what they found was inflammation. That was
Mhm.
2007. One would think that a study like that, I mean, that's a pretty critical finding. Like one would think that that sends off alarm bells throughout the community that we're missing a treatment avenue, that someone like Frank Duffy maybe was onto something, treating with steroids at that time, which are not benign, by the way. Like we don't want to just, I mean, that's not the answer is to put everybody on steroids. But the point was that at least he was identifying it and treating inflammation. And then you get this Vargas pathological study showing inflammation, and you think that's really critical. That's a critical finding. And then you think to yourself, okay, now of the kids I've seen, and I'm talking about a lot of the kids who had that sort of neurodevelopmental regression, that population really high rates of other autoimmune type things. So whether it's asthma or eczema, which is really common, or allergies, multiple food allergies, certainly celiac. And then you have this entity of autism enteropathy where kids have kind of a unique pattern of gut inflammation. So again, gut inflammation, it's just part of that bigger inflammatory picture. And then I have had kids with a whole host of other inflammatory things. So I have kids who have Crohn's disease and autism, but the autism came first. The Crohn's came later, but the inflammation was there the whole time. I have kids who have rheumatoid arthritis and autism, and generally the developmental regression came first, and the rheumatoid arthritis came much later. But again, the inflammation was there the whole time. They just didn't have that rheumatoid arthritis diagnosis until they were maybe a teenager, but it's not as if they were without inflammation through that whole course. And so it raises a question about whether, and so this is why I actually was hesitant to talk about co-occurring conditions, because it really raises the question about whether it's a whole body inflammatory condition. It's not
Yeah,
just brain, it's not isolated to brain, it's affecting multiple organ systems in a lot of kids.
right.
And again, if you're 70 and you had such a state, it would be treated. It would be diagnosed and treated. Um, and I think, if I had to wager as to one of the reasons we're not addressing it the way we should is that for a lot of these kids, they're non-speakers. And when you're a non-speaker, the world's a lot easier to say it's genetic and there's just intellectual delay, and that's all there is. And there's nothing more. But when you actually put some faith in the fact that there's really a kid inside there, and you treat the inflammation, and you begin to actually see that the motor skills are improving, the language is improving, this kid is opening up, and there's so much more, and we're just scratching the surface. And then you get into like a frenzied state that like I want more and more and more, and you don't want to stop. And so I think that's where it's really important to really rethink our paradigms. And then once you open up that inflammation can of worms, it actually leads down a few other pathways, because then the next thing you start thinking of is the gut microbiome, because that's really critical to inflammation. You have to start thinking of also the metabolic state of that kid too. Is there mitochondrial dysfunction? All these things go together. And then you think about what are the other kind of environmental stressors on that kid? Are there toxins or other environmental stressors that lead to oxidative stress? All these things intersect and they all interact together. And so a very simple way to think of it is if you think of the brain not as a physical organ, but if you think of it purely energetically, something like inflammation sucks that energy away. And it's useless energy suck. And for many of these kids, they also struggle to produce the energy they need. They have mitochondrial dysfunction. And a high percent, as many as 80% of kids also have mitochondrial dysfunction. And these things are not separate entities. They actually work together. They feed on each
That's,
other.
hold on a second.
Yeah.
80% of kids with autism have mitochondrial disease,
Dysfunction. And so I'll
dysfunction.
separate those out. Yeah. So
Okay.
this is from Richard Fry's work. And so the difference between dysfunction and mitochondrial disorder is an important distinction. But mitochondrial disorder is when you have like an abnormality of the mitochondria itself that can't really be solved. So it's like usually a genetic disorder of one of the mitochondrial genes that really inhibits the mitochondrial function. So it cannot function as it should. And when you have mitochondrial, so that's a disorder, but when you have dysfunction, it means that there's generally some environmental factor that's preventing mitochondria from functioning optimally. And as a result of that, the brain, which is the most metabolically active organ we have, and it's also the most metabolically active between the ages of 2 and 6. Okay, so this is like a gas guzzler. Think of it
Mm.
like it's like a high performance engine. It needs high octane gas to run well. And that high octane gas is coming from our mitochondria. But unfortunately, when you have inflammation and you have gut dysbiosis, those things are going to negatively impact the mitochondrial's ability to generate the energy the brain needs and at that critical stage. And so on the one hand, you have inflammation that's like sucking away that energy, and on the other hand, your ability to produce the energy you desperately need is limited too. And what that does developmentally, none of it is good. I mean, it's just, and then if you throw something like seizures into the mix, because as many as 30 kids with autism have epilepsy too. And then you think about kids who have like really frequent spike waves through the night, like abnormal electrical discharges all during their sleep. Energetically, the only time the brain can really heal and recover is during sleep. And if you're having either seizures or you're having a lot of abnormal electrical activity at night, that's another energy suck. So now you have inflammation sucking energy away. You have seizures or spike waves sucking energy away, and then and the energy you need to make, your mitochondria are not prepared to make it and are not capable because they have too many other stressors on them. And so as a result, you start to like overproduce your mitochondria a little bit to try to compensate. And that's what we see in a lot of kids with autism is that they actually have a higher content of mitochondria, but it's a compensation. So if you do, there are studies that you can look at mitochondrial function using cheek swabs, and so it's a pretty non-invasive way to test them, and it's pretty concordant if you with doing like a muscle biopsy. It's about 75% equal to what you'd see in a muscle biopsy. But really, for a lot of kids, what you see is their mitochondrial content is a little higher because you're trying to compensate. But usually, the different complexes of the mitochondria generating energy often showed that's where they show a reduction in their ability to produce the energy. And so that can be measured. We don't always measure it, but it raises a question here about the fact that you have multiple systems affected, not one. And so I mentioned its whole body, but even at the cellular level, you have a lot of different systems to work on. You have inflammation, you have to support the mitochondrial functioning, you have to help and provide antioxidants to remove that oxidative stress. So it's not a single treatment. It's like a whole biological system that intersects, and you have to treat the gut microbiome. And then you have to get rid of any allergies and any toxins, black mold, you name it. Look for Lyme, look for all the things that could possibly lead to a regression or make matters worse. So none of that came from my pediatric training. Literally all that came from a lot of smart moms who put me in the right direction. And then, yeah, I'll admit I did the reading, but the actual like the proof is in the pudding. So actually seeing the kids get better and listening to the stories, once you see a kid recover or once you see a kid move in that direction, you don't want to stop. It's a little bit addictive. You want to keep it,
Yeah.
you want to get every kid towards healing that you can possibly see.
I think that we're still unfortunately stuck where a lot of families don't even realize that autism is a whole body disorder. We're still diagnosing it like this mysterious mental disorder, um, um, as was done when my daughter was diagnosed a very long time ago. And you go in and you have a developmental pediatrician and a team of people, and they're looking at motor skills and communication and all the typical things. And they're basically just observing behaviors and observing the skills that your child has. And then they check off this box, this box, this box. Okay, yep, autism. And then they give you information on early intervention and they send you on your way. But there's no why, there's no what's going on with the body. There's there's nothing. I mean, so the people who get to a neurologist are typically the families who have a child who has some really serious issues like epilepsy or something like that. But if you're sticking with your developmental pediatrician, you're not going to dig into what might be helpful, like any kind of gut intervention. Like I'm gonna talk about the gut stuff for a second.
Yeah.
Because another thing that's really common with our kids is they have gut problems. So they'll have chronic constipation or diarrhea. There are so many doctors on the like developmental pediatrician side who will tell parents, oh, that's just part of autism. So as a parent, if you have a kid who has chronic diarrhea, like acidic diarrhea that's literally burning the skin on their bottoms and their legs and everything, and the doctor tells you, oh, that's part of autism. Eileen, like as a parent, when do you insist on getting like some other assistance here, like seeing a specialist? If it was obviously, you're comparing a 70-year-old that has some kind of a mental change, but like when do you send a kid to a gastroenterologist for their GI problems? It's very common in kids
Mhm.
with autism, but it's not part of autism.
Yeah. So, well, there are two parts there. So one is going to be the DSM-5. We'll get to that. I'll get to the GI first. But this is the reality is like a lot of times, not all gastroenterologists really want to see or treat or listen to the concerns in autism. And so you do have to find the right person. You have to find somebody who can make the right approach. And the other thing to know too is that there are some gastroenterologists who do identify autism enteropathy. And what I'm talking about here is a very specific pattern of inflammation that you really don't see in other patient populations. It doesn't quite fit Crohn's or ulcerative colitis. It's sort of its own unique subset of inflammation, a little more subtle to identify. But the kind of finding there is that if they do an endoscopy and colonoscopy, they see evidence of inflammation. It looks like there's just like in general an inflamed GI tract, but it's a little more subtle than what you might see in, say, Crohn's. But not all gastroenterologists will identify that entity or treat it. And one of the things that is important to think about is so Dr. Krigsman is one of these gastroenterologists who really does one of the first to really identify this as an
Mhm.
entity. And he does treat that as inflammation. And when he treats it as inflammation, the kids do developmentally better and behaviorally better.
Would have to because they'd have to be in pain, right? And
Not
and
and
pain leads to behaviors or self-injurious behaviors or aggressive behaviors, especially if
I
they're not speaking.
I think that's true, but I think it goes beyond that. I actually think when you treat the inflammation, you're treating the brain inflammation too. So I think it
Hmm.
goes a little bit beyond just the pain. I think it begins to be like whole body healing in a sense, because what's happening in the gut is really it's probably happening in the brain as well. We just can't see the brain,
Yeah.
and so I think that I think is really the most likely scenario. But I do think we have to think too about when it comes to gut brain. This is where it gets a little hard. Is it is a two-way street. So you can have GI symptoms that are purely neurological, and then you can have neurological symptoms that are really kind of coming more from the gut. And this is so it gets complicated. But I'll give you an example of like a purely neurological circumstance that definitely affects the gut, and that would be in the case of fight or flight. If a kid has a fight or flight episode, and you get that sudden surge of adrenaline, it's very common that you might throw up or have some direct GI complaint, pain or vomiting. I do have some patients who are so anxious just to come to the doctor that they actually throw up on the way to the office, and I might have to use an antiemetic to kind of calm that. That's not usually the type of response I want to, give kids. I try to be nice and friendly, but it's just the thing about the doctor's office. But no, I do have kids who really they have that direct fight or flight, which is triggered from the brain, directly affects the gut because the gut motility I mean, you have to think that our intestines are entirely covered with neurons, with nerve endings, just like our skin is. It's just that we can't pinpoint the sensation the same way. On the other side of it, more than 90% of our neurotransmitters are produced in the gut. And so that's interesting. And then the other thing too is that our general metabolic health and inflammation is very much dependent on gut health because when you have a healthy gut, your bacteria produce butyrate and your bacteria also produce small chain fatty acids. And those two things, when they get into the bloodstream, they actually improve your mitochondrial functioning and they lower inflammation. And so when you have a healthy gut, you begin to have a healthy body and a healthy brain as well. And it becomes a two-way street. And obviously, when kids, if you have a non-speaker who, um, and this is one of the sad parts, I guess, of current state of care, but if you have a non-speaker who's experiencing pain and they can't verbalize the pain or pinpoint it for you, it's all too common that they're treated with an antipsychotic for their
Hmm.
symptoms. So if I had a cavity and I went to my doctor with a cavity and they gave me an antipsychotic, that would be clear, pretty blatant malpractice, right? I think.
Right.
Also, if I had severe abdominal pain, if I had GI inflammation and so or severe constipation, and and you give me an antipsychotic for that, that's really not good practice at all. And but we do that every day. And so I do have to kind of mention the non-speaker because for non-speakers, unfortunately, when they experience GI pain, they might strike their head, or they might not sleep, or they might just stim a lot or look really agitated. And how am I going to figure that one out? Well, there are ways to do it, but you have to really look at the history. Like if you have a kid who all the symptoms get better after bowel movement, and they're constipated, like, okay, that's probably what we're talking about. If they have reflux, that's a little harder, but reflux kind of comes quickly. And a lot of kids have eosinophilic esophagitis too, EOE. That's a really common thing in autism. And so swallowing hurts and reflux hurts. And I
Hmm.
can't see that. It's really hard to tell. But I can kind of start to gauge that with like, how does it relate to what they ate, when they ate? How about when they take their pills? Do you see those behaviors come out at those times? You have to really begin to look for those subtle clues because in those, that's where you're going to hopefully figure out what's behind those behaviors. Because for every non-speaker, they absolutely communicate. They may not use words, but they're communicating all the time.
Hmm.
And there's never a situation where a kid is not communicating. It's just a matter of like, are we listening the right way? And so that's a long-winded way to say that the gut-brain thing is complex, but it's a major, major driver of the behavior, and it has to be treated. And you've got to like seek out food allergy, and you got to figure out if a restrictive, like a gluten or casein-free diet is right for your kid. It's worth a trial. And so you've got to go through those, and you've got to clean the diet too. I mean, all those things are really important. And I think it's always worth using a probiotic. And I've kind of transitioned a little bit from pills for that to making, even for kids who are dairy free, making sometimes dairy free yogurt. I like to make sure we're giving foods that help feed that healthy gut microbiome through food. I think it's great to do as much as we can through food as possible. So that's a long-winded approach to the GI part. But all I could say is like sometimes you see like your gastroenterologist who's not autism focused, and you may not get a lot of these recommendations or insight. You might just get scoped, and maybe that's helpful, but if they don't really know what they're looking for, it might not be.
Yeah. And I think it's really helpful for parents to to make note of patterns, like when are they seeing certain behaviors or adrenaline spikes in their kids or elopement attempts, that kind of thing. Like keeping a log. What did they eat all day long? Did they sleep last night? You've talked about mitochondria, so 80% of people with autism have mitochondrial dysfunction. What are the other more common things? Obviously, inflammation is one of them. Gut problems. What do you see? Like you got a new patient just coming in the door, you're going to ask certain questions. What are you asking? You're asking about like behaviors and skills, and then because you're literally a detective. You went from being a neurologist to now being a GI doc and like metabolic specialist, and like you're a detective. So how do you approach it with a new kid in your practice?
Well, well, first, I don't have to be too much of a detective because I usually just, we've already established, I just kind of ask the mom what they think is going on, and they tell me, and then it's like, yeah, that kind of makes sense. But that's part of the visit. But they've done most of the detective work. That's my point. But I'm going to backtrack a little to the DSM-5 part, and then I'm going to get to that, if
Okay.
that's okay,
Yeah.
because it's all sort of tied in. Because ultimately, what I'm going to kind of get at in terms of what I'm looking at, what are some of the kind of co-occurring conditions, really ties into that DSM-5. Before I get to the DSM-5, though, it's worth noting that one of the really critical things, though, is regression. Kids who had regression, neurodevelopmental regression, really are a different subset of kids. And we have to recognize that the term autism is such a broad spectrum. It's not a true diagnosis. It's just a collection of behaviors that happen to fall under the same heading. It is not a diagnosis. It's not medically based. And so when we think about like what are co-occurring issues, I think it's really important to subdivide the populations that we're talking about and think about, really think about those kids who had regression because they truly are unique in terms of their concerns and the things that you look for going forward. Just to backtrack for a second on diagnosis. So, when you think back to when autism first came about, the first description that most people point to is Leo Kanner's description. I think it was the 40s, it was written in. And, he was at Johns Hopkins and he spent about a decade to compile 11 patients in his first case write-up, which is, I could do that in an afternoon, but it took him like more than a decade. Just that gives you a little sense of how common it was back then. And it really suggests it wasn't so very common. The other thing to note too is that in that time in history, so much of medicine was being driven by Freudian psychology. Freud had a major influence on everything, and we really believed that so many disorders that are rooted in biology were actually rooted in psychology. And obviously psychology is really important, but something like autism, when your kid has clear signs of inflammation and epilepsy and, had a neurodevelopmental regression, that's not psychology. Unfortunately, the importance of psychology, though, was so profound that it really was the primary focus of what the cause was for decades,
Right.
going up
Refrigerator
into,
mothers.
yeah, so
Yeah.
that phrase came from Kanner himself. In his original paper, he used the term emotionally refrigerated mothers. But he also spoke of the fathers who were more wedded to their work than to their children. And so, he's putting a lot of detail in there about the dynamics of the kids and the families. What he wasn't mentioning there was regression in a lot of those cases, which is sort of interesting. Because when you think of regression, it didn't really start to show up until about the 80s. You start to see more about regression in the 80s. And now it's somewhere around 30-40% of kids with autism had a history of regression. We just don't have great studies on it because we don't subdivide it out that way. But regression is really critical. And so if you march through now the 80s, 90s into today, though, we have what's really predominated in our psychology is genetics. And so in the 80s, we started to think like maybe genetics will answer all of these questions for us. There's a real question between what's nature and what's nurture. And that's always been at the heart of a lot of questions. But we started to think, okay, this is all genetic. We swung the pendulum 180 degrees the other way and start to think like instead of all psychology based, maybe it's all genetically based, and we'll just find that gene for everybody. Well, as time went on, now we can actually sequence the entire genome, and anybody can go do it. It's not impossible anymore. You sequence the entire genome, and after doing that, at best, you can get an answer for about 25% of the families with autism, meaning 75% don't have an answer. When you look at kids who don't have syndromic features, like meaning they don't have facial dysmorphology or other signs that something formed abnormally in utero, the hit rate for genetics is even lower. It's around 6%. And most of these kids, one thing Kenner got right, well, I don't know if Kenner came up with it, but I think it goes back to that time. I think one of the mentions in his paper was that the kids were actually quite handsome. And that is true. I mean, I would say that's the one thing that is true. But that's also significant too, because in a lot of genetic conditions, like sometimes there is a difference of, kind of like facial structure or body structure. But so many of the kids, like, that's clearly not present. There's nothing that seemed to form abnormally when you see them that kind of speaks to that sort of genetic condition. And then they do the gene testing, they've done the whole exome sequence or whole genome analysis, and still the majority of kids are left without an answer from that. So then it raises that question. Now, some of the geneticists will say, well, it's instead of one gene, it's actually multiple, and maybe it's the way they're all interacting. It's There could also be environmental factors, right? I think the most obvious thing is that there are some people who might have a predisposition, but given a certain environmental circumstance, there are some kids who are more susceptible, like the canary in the coal mine
Yeah.
thing. Yeah. The problem is we're seeing more and more kids affected over time. Um, but the reason regression is so important is I think it speaks a little bit to the environmental triggers, to the importance of inflammatory triggers. And it tells you that there's something in that child's biology that's very, very different than kids who lack those medical features. Because many of the kids who didn't have regression, many times they're totally medically healthy. They don't have GI pain. They don't have eosinophilic esophagitis. They have mild autism. They're speakers. They don't have the significant motor issues. They have maybe a lot of OCD, some executive functioning issues, but they lack all the medical stuff. They don't necessarily need to get that intensive biomedical approach. But these kids who had regression, they're totally different. They're the ones who had frequent infections, didn't tolerate those infections, had those regressions in the setting of inflammation. They had the GI symptoms and the GI inflammation, you name it, eczema, eosinophilic esophagitis, all these other what we think of as comorbid conditions. I think the way I view those kids is they were showing us at an early age that they're having trouble managing that kind of medical stressor. And now that I've been following the same kids for a while, I'm starting to figure out that that doesn't fully go away, which is a hard message, but it also speaks to the importance of staying on that medical path. Because when so a lot of these kids they had that significant regression age two, they start to make progress and they're doing okay. They're getting their ABA, they're rebuilding their language, they're starting to do okay. All of a sudden at age 10, 11, 12, the bottom drops out again.
Hmm.
And maybe testosterone plays a role because that's certainly not always a good thing to get hit with testosterone. But on the other hand, a lot of times these kids actually did have another inflammatory trigger, another infection, another febrile illness, something else that led to it. The bottom drops out, and then suddenly you have severe OCD, not leaving the house, self-injury, aggression, and sometimes seizures and epilepsy. And of the kids, I looked at my own patient population on this, and of the kids who had a neurodevelopmental regression, about 45% would later, around pre-adolescence, would later develop epilepsy and self-injury. So almost half of those kids with regression were developing that. If you looked at the kids without regression, that number was like 20%. It was much lower number. So it kind of tells me there's something unique here. And even the epilepsy raises some questions about how inflammation might play a role because the typical cycle of these kids, this is not like epilepsy in anyone else, because what you usually see is for a lot of the kids who experience this, they will have a cycle where they have a gradual buildup of their OCD. They're getting more self-injurious, they're getting a little more aggressive, they're not sleeping. It builds to a really bad point. Then you go about 2 nights without sleep, and then boom, a seizure happens.
That's exactly what happens to my daughter.
Yeah, and to a lot of families, because then the seizure happens and everything's good for about 3 or 4 days.
Yeah.
Like self-injury, everything went away. The OCD, the kids actually communicate a little bit better, but then the buildup, it comes back. It's like
Yeah.
waves on the beach.
It's like a reset when the seizure finally hits. It's
It's
like
like
a
a reset.
reset that she's clear. And then we'll have, you'll have a good stretch, sometimes weeks. And then it starts to build and you can see it. It's so clear. You see it, you know it's coming. Oh, but
It's,
how often can we talk about hormones for a second? Because
that's an
talking about
important part of this.
adolescence, you
Yep.
know, I I I mean, I know what happened. My daughter, she didn't start having seizures until she was 13. But that's pretty common in the autism community for kids to not have epilepsy when they're younger, but when they hit adolescence, are you are you still seeing a lot of that? I know you know, at the
It,
time you were.
yeah, so the hormonal piece is really important. So this is where, if you remember the Geyers were talked about testosterone back like 20 years, something like
Yeah.
25 years ago. Yeah, so the kids who develop when kids develop self-injury and aggression, it's usually in that pre-adolescent stage for the boys, and one has to think testosterone plays a role here. Um, if you think too that a lot of the kids who experience that, they have executive functioning challenge and they already have some trouble with impulse control. So you give testosterone to someone without impulse control, and what you get, it can look a little like you see this actually on any college campus on a Friday night. There's a lot of testosterone and there's a lot of alcohol, and you mix those with the alcohol, you wipe out your frontal lobe, you have no impulse control, and then you see unbridled testosterone, and what happens? Which is why Which is why I told my daughters to, stay out of the lacrosse house when they went to college. Just you can go anywhere you want, but just don't go there. Nothing against the lacrosse player. I'm sure there's a lacrosse player on. I love you guys. No, but that's you can see that effect in a neurotypical neurotypical male. Now, I do think that that combination is playing itself out a little bit too with things like elopement or self-injury, because there's one other feature here that's happening is the fight or flight is triggering too. So you have the testosterone, so you have a little more aggression at baseline. You have a little trouble with the impulse control, but then a lot of the same kids are triggering fight or flight quite often, and that's going to make you run or fight. I mean, and if you have that impulse control challenge, it's just a bad combination. And so it requires really getting a handle on the adrenaline piece. I think what the guys were proposing was getting a handle on the testosterone piece, but you really can't do it. You can't suppress testosterone. And the reason is like you don't develop your muscles and bones the way you should. And at some point, you have to let the kids develop muscles and bones. I mean, you just can't suppress it ongoing. And what we do see is as the boys get older, it does settle out. It does start to even out. But sometimes it takes until their 20s. So they need really good solutions to get through the self-injury and aggression when they're
Yeah.
10, 11, 12. And that's a whole art in and of itself. I think self-injury and aggression are a whole unique challenge. Really important to know. And my personal goal is to do it without ever using an antipsychotic. That's what I set out for. And a lot of times I'm able to do it with a combination of things like propranolol for the adrenaline, sometimes for extreme sensory issues. Sometimes I'll use naltrexone, which is also a good anti-inflammatory, and then just good general health, like trying to use a combination of anti-inflammatories and other sometimes herbals too are quite for calming as well. But that's a whole separate art in and of itself, but I'll get into that. But then for girls, you have a different story though hormonally. So girls cycle, and so you start to actually, you can begin to appreciate what the relationship is to the menstrual cycle and either injury, aggression, or epilepsy. And the major thing there is that, but what's good to know is that like estrogen tends to be more excitatory to the brain and progesterone tends to be more calming. Natural progesterone breaks down to something called allopregnanolone, which is a GABA agonist. It activates GABA receptors, and so it calms migraines, it calms seizures. And so sometimes in girls, you can actually consider using a natural progesterone product to sort of ease those symptoms through their cycle, through the worst part of it. So girls do offer a potential hormonal treatment. We don't really have an equivalent for boys at this stage.
Okay.
Yeah.
Okay. So, for parents who aren't working with a doctor that's addressing the underlying medical stuff that's going on with their kids, what are the more common interventions and effective changes that you can make? I'm gonna guess you're gonna bring up dietary interventions, which are huge, and because they're related to inflammation, can you touch on that for just a few?
Yeah, so the basic interventions actually start with the really simple stuff. So like the lifestyle stuff. So it really begins with nutrition. That's number one. And then, sleep and getting fresh sunshine, like sunshine and fresh air, really important. So exercise, really critical. Like the really basic stuff. If you don't get the sleep and the nutrition and the exercise right, anything else you're going to do is probably not going to work too well. So it doesn't make sense to like jump right to a med if those things are way out of whack. Every now and then I have a patient who comes to me and the very first thing they explored for treating their kids' autism is stem cell therapy. They like jumped right to that,
Wow.
got on a plane to Panama. It's like, okay, that's not your first step. You got like, there's a lot of things we could do before we get to that. Um, so yeah, so oh, and by the way, yeah, and just to mention, I did do that a talk on self-injury at the 2022. Just
Yeah,
mention that real quick.
Crystal was just sending me a note about that to mention that you did that in our 2022 conference and it is on our website. So that is about self-injury and aggression. So if you guys want to see that, we'll have it. We'll put a link up.
Yeah, okay, good. So I did cover that, and I forgot that that was the topic I covered then, but that's good. So the more details from that talk if you wanted to see that. Yeah, so boy, now I forgot where I was. Now I need
Where were we?
Oh, the lifestyle.
Hormone.
Yeah, so getting those basic things right is really where we start. But
Oh,
then
diet. Yeah.
yeah, and nutrition is really the hallmark of it. So one way to think of it, there's a couple things I think that are interesting, but I was in college, I majored in agriculture. So I went to an agricultural school. I did my senior thesis on peaches. Um, okay.
Okay. Wait a minute.
So
I did not know this.
I
Now I
did.
have that.
So
That song is in my head, but it's
Yeah,
okay. Go
yeah.
ahead.
I did that before the Presidents of the United States came out with their peaches song, but and
Okay.
that had nothing. So that had nothing to do with my senior thesis. I actually liked peaches. I like to eat them, and I like to try all the varieties. However, when I did that work, a couple of things are instructive there. So, you do when you do agriculture, you learn like something. You learn plant pathology. If you have a plant that's sick and the leaves are wilting, sometimes what you test is not the plant itself. You test the soil. If you have a kid that's sick, we test the hell out of the kid, but we don't look at the soil.
Yeah.
But you have to really think of it as when you're raising a child, you're basically a human farmer in a way. You're farming a kid. You wouldn't raise crops with terrible soil and terrible water and no sunlight. Kids are not any different than a plant. They need great soil, clean water, and a lot of sunlight. And that's really the key. That's one thing that comes to mind. But the other thing that really came to mind too is the fact that working in a peach farm, because I had to collect samples there, I would come home from work those days, and the first day I did it, I smelled like pesticide, head to toe. So like anybody would, you take a shower, you throw your clothes in the wash, you wash them out. I smell my clothes. After the wash, they still smell like pesticide. So I wash them a second time. They still smell like pesticide.
Wow.
And then that was like an aha moment, like, wow, okay, that's a lot of pesticide. Like, if I can't get it out of my clothes with 3 cycles, what on earth am I eating? Um, you begin to think about that. And we know that glyphosate, I mean, it's important to take a second to think about what we use for crops. So I talked about genetics and and medicine. Now, genetics has been used in plants as well, and that really goes back to, in the 90s, we were talking about the first time that we can use genetically modified crops. The reason they did genetically modified crops is so that you can actually douse those crops in more glyphosate. That was the purpose of it. So now you have these genetically modified crops that are glyphosate resistant. You can't kill those crops, but they kills every other thing around them. So what you're eating is a lot of glyphosate and something that looks like a plant.
Yeah.
So, and that's what we in most of our wheat and grains. I mean, we have like high levels of glyphosate. Atrazine's like the number 2 herbicide used, and this is a large portion of what we're eating. And so I do think and that's a pro-inflammatory. Glyphosate is not good for the brain, nor is atrazine. There was a study in atrazine linking it with neuropsychiatric conditions in kids. One would think that we would have massive studies and research on these topics. Like it
Yeah.
just seems logical, and
Wasn't
we
there a
don't.
study on glyphosate with Stephanie um she's from Boston, a scientist. She
I
did a
don't.
study on autism and glyphosate. Did she not?
That's a Yeah. I didn't. I missed that, and I'd like to look at it. I think it's a logical thing to look at, right?
Yeah.
Because again, when a plant is sick, you test the soil. When a kid is sick, we need to test the soil. What are they eating? What are they exposed to? What kind of water and food and sun are they receiving? That's really important to look at. And of those, the nutrition, the food is number one. So
Cleaning up the food, organic food, real food,
yeah,
not
getting rid of
processed
allergies.
food.
Yeah, getting rid of any foods that you're allergic to. And that for a lot of kids is gluten or dairy. Those are 2 big ones. But for a lot of kids, things like strawberries, peanuts, you name it. Anything you're allergic to, you got to get rid of.
Hmm.
You might be able to build that back later, but initially you have to get rid of it. Clean food sources. You don't need red dye 40. You don't need nitrates. You don't need monosodium glutamate, right?
Yeah.
Um, and so these are all really important things to clean up because none of these things are good for a developing brain. And so I'd say food is really kind of the number one thing. But then there's a more interesting part about food is that like there's some studies on keto diet and autism, and we haven't done enough of that work. We should do more because some of the studies showed really dramatic improvements, pretty consistent ones too. And pretty much all the studies did, and these were in core symptoms. So that's really important to note. And so when you do a keto diet or a low glycemic diet or a modified Atkins diet, you're basically removing most carbohydrate from the diet. And so you're using fat as your primary fuel source. And when you do that, you actually change your mitochondrial machinery. You increase mitochondrial functioning and you lower inflammation. You do the 2 things that you really need to do to treat kids to help them heal. So that's a
Yeah.
really important tool, and it's really helpful for epilepsy too.
Parents, you need to hear this. Low glycemic index diet, keto diet, look at it. This is so my daughter is 20, she's about to turn 26. We started a low glycemic index diet in June, and she is like a different person from that diet. She is so, I think because there's no sugar spikes, you know what I mean? She's so regulated all the time, every day. There's none of this up and down and um, like unexpected behaviors. It's just not happening because she feels good, you know?
Yeah, and actually, a lot of neurotypical adults are saying the same that they have that kind of mental fogginess is gone when they go low glycemic. I have a cousin who has rheumatoid arthritis. She went low glycemic. She came off of three of her meds. That was
Yeah.
sufficient to treat her. Did her rheumatologist tell her that? No. She did it
No,
from, she had to read it on her own and try it on her own, and then it worked tremendously well for her and better than any of the meds she was on. It really raises a lot of questions about what on earth we're doing medically that we're ignoring.
it really
Um,
does. And the things that parents, especially things that you can do without a doctor, like it's so important because there's so many people who don't have access to a doctor like you. It was Stephanie Seneff, if you want to look up her study on glyphosate. That's who it was. Thank you, Crystal, for sending that to me. We also had a question from someone who's tuning in about testing for mitochondrial disease and dysfunction. What basic tests should parents request from doctors?
yeah, so the mito disease and mito dysfunction are, again, they're two different things in
Mhm.
terms of how we test. So mito disease is when you have a genetic, like usually genetic mutation of one of the mitochondrial genes that affects the structure of the mitochondria, so it can't produce energy as it should. That can be identified through mitochondrial genome testing. Um, the other way you can identify it, though, is you could do, in the old days, we would have to do a muscle biopsy before we had the gene testing. And of course, like everything else in medicine, starts with a history. So you have to kind of have a history that supports mitochondrial disorder. And the kinds of things we would see in kids, people with mitochondrial disorder, it could be things like growth failure, like a failure to thrive. You see that in MELAS, for example, migraine headaches, sometimes epilepsy presents. Developmental regression, particularly an intolerance to infection, so when kids with mitochondrial disease get sick, they get really sick, and it takes them a lot longer to recover. It sounds a lot like our kids with autism, doesn't it? Sometimes you can have hearing loss, diabetes. So there are different features we look for that are all features of mitochondrial disease. Mitochondrial dysfunction, there's some environmental thing that is negatively impacting the function of the mitochondria. So that could be a medication, it could be an external toxin. I think you could even throw food in there to some degree because if you develop things like obesity or you have a really high glycemic index, really high insulin levels, that's not good for mitochondrial functioning. It's not optimal. So when you have mitochondrial dysfunction, you're not going to pick that up on the genetics. You're going to pick that up by measuring, looking at cells and looking at how well their mitochondria work by testing the electron transport chain. The most common way to do that, you can't really just do a brain biopsy. Nobody's going to do that. So the most common way is you have to look at really highly energetic tissue. And that would be brain is highly energetic, but next comes muscle. And so we would do a muscle biopsy, and then you would measure the electron transport chain, the different components of the mitochondria that produce energy that we all learned about in 10th grade biology. You measure each of those components and you see how well they're functioning, and you can identify like which component is not functioning. That's how we used to diagnose it. But for a lot of the kids with autism who want this kind of testing, we do it actually through a cheek swab. So there's a test called the Mito swab. It's an out-of-pocket test. But what you're doing is you're taking the cells you're rubbing off from the cheek, and you're using those cells to test. So it's non-invasive. And it actually is concordant with the muscle biopsy about 75% of the time. So it's pretty close to a muscle
Wow.
biopsy. So it's a good screening test to use. And the other thing to know too is that there was a recent study that looked at the use of a mitochondrial cocktail in kids with autism, and they did show developmental improvement, but they also showed actual measurable improvement in their mitoswab testing. So I think that's also worth noting.
What caused the improvement?
Well, the fact
Can
that
you talk about the mitochondrial cocktail? Just so
yeah,
parents know what you mean.
Yeah, it's sort of like a margarita combined with a mojito, like Cosmopolitan. No, it's not that kind of cocktail.
Okay.
You're ready? Um, like three parts triple sec. No. So it's basically instead of triple sec and vodka, it's basically CoQ10 is really important in the form of ubiquinone because that's really one of the core things. High dose B vitamins, and usually in the methylated active forms. And then you'll also have other components like vitamin E, D, C, but then some things that are not seen in multivitamins. So creatine and carnitine, sometimes arginine, are things you're not going to find in a standard multivitamin. And
Mhm.
so you can get a mitochondrial cocktail of vitamins either by going through, there are some compounding pharmacies that are really used to making these for patients. And so you can get it from a compounding pharmacy, or you can buy certain products that are kind of pre-made for this. Either way, it's usually not covered by insurance though. However, the clinical trial I mentioned, it was only 18 patients, but it did show improvement in core symptoms. And I usually use that as one of my standard approaches. I also use folinic acid, which is leucovorin, pretty commonly. I pretty commonly use sulforaphane, which is a broccoli extract. These are all things that have really shown in clinical trials some improvement in core symptoms. I very commonly use gut microbiome treatments, so I like to use either probiotic or have kids make their own yogurt. If you make your own yogurt, you can do it dairy free. But when you make yogurt, you know that it's active because you just made it. If the culture wasn't active, it wouldn't turn to yogurt. And if you're going to make yogurt and if you want to sweeten it, you can use raw unfiltered honey because honey's loaded with antioxidants. So it's great. It's a great way to, but you want to use a raw honey, because you want to
Mhm.
get all the goodness from that. And so, this is where I think it's interesting that food, can be that medicine. And I'll add one other part that is kind of interesting on that approach is that, for cannabis has had a little bit of a place in autism treatment too. And that's another place where I've had parents who themselves would grow a strain that's high in cannabidiol and extract it and make it and put it into an oil for their kids.
Mhm.
And I also have a mom I see who's gotten really good at growing lemon balm for her daughter. She has lemon balm growing in the backyard. She extracts it. She gives it to her daughter. And basically, her daughter used to be on a psych med to help keep her calm and less fight or flight. Lemon balm's been doing the whole thing. And I
Wow.
just mention it because think of the beauty of like you breastfed your kids, they grew in your belly, you breastfed them, and now you're making their medicine. Like that's like you grow it in the backyard, you extract it, you're putting that love and care into it. I think that's like an amazing thing. And I'd love to live in a world where we could do a lot more of that because I really think it's possible. You can make yogurt, treat the gut microbiome. You could, if you're really crazy, you could have your own bees and make honey. How cool is that? If you need cannabis, it could be grown. Lemon balm could be grown. There's a lot that we could do herbally that we're probably not touching on. And that's where, I think, I do question, we haven't done studies, and I know my colleagues would say there's no science behind that. There's no science behind that because in order to do a clinical trial, somebody's got to pay for it. And who's going to get paid? Where's the big pot of gold at the end of a lemon balm study? There's no pot of gold there. Nobody's getting paid. Nobody's making money off of that. So
Right.
nobody's going to do the study. And that's the sad thing. But I do think there's a lot that is untapped that we need to still explore.
All right. Well, let's end this chat tonight on a hopeful note because that is hopeful to me. But maybe a message to parents about how they might be able to help encourage their physicians to maybe get trained by MAPS, go through the fellowship program. We really appreciate your work on that, bringing so many more doctors on board that are able to be the detectives that our kids need from a medical thing. If you could touch on that and maybe just leave us with a message of hope on the state of treatment right now in autism.
Yeah, I think there are a lot of ways that we're going to see things improve. I think one thing though, I guess it's not so much message of hope, but it's just a recommendation is that when you feel it in your gut, if you're with a provider who's like listening and understanding, you feel it pretty quickly. And I think you know this in the first 5 minutes of the encounter. If you think back to, every parent has to do that parent-teacher conference night. And in about 2 minutes, you kind of have a gauge if that teacher knows your kid or that teacher doesn't know your kid. And if that teacher doesn't know your kid, you kind of know that you're in the wrong place, right?
Mm-hmm.
But when the teacher goes in there and tells you like, everything about your kid, all these observations that you thought you're the only one who made, and they picked up on those, you're like, I'm with the right person,
Yeah.
right? It's no different when you meet a doctor. You got to approach it the same way. You're going to see really right away simple things. Did the doctor come in and actually talk to your kid, even if they're non-speaker? Did they address them? Did they talk to them in baby talk, or did they talk to them like a 15-year-old would, or
Yeah.
whatever their age, right? Are they listening? Did they really hear your story? Did they process it? Did they, and did they really give you time to like share some of your ideas on what would work for treatment? I think all those things are really important. And I think if it's not a good fit, I wouldn't try to put a square peg in a round hole. I just don't think this is maybe not the message MAPS wants to know, but I don't think every doctor is MAPS doctor. I really
Yeah.
don't. I think it's the people who listen, and I think it's the MAPS doctors are really the people who see the kid and not the diagnosis. And that's really the key. And when you see the kid and you realize this is a really smart kid, and I want to get more out of it. I want to see more that's the smarts. And that's when you start to say, you know what, like this spelling thing is amazing, right? There are doctors out there who still don't believe in spelling at all, and they think it's all like a hoax or a Ouija board. I mean, I'll spend the rest of my life trying to show them the truth, but I may not get there, right? I may not get there for everybody. But what's really behind that is the fact that it's not so much about the act of spelling, it's the fact that the kids are really smart. And
So
and we didn't
smart.
and yeah, we didn't give them that credit. And then not only are they smart, but they are deeply compassionate. They are very socially connected. So then you start to think, well, what were those core symptoms of autism? What's in that DSM-5 criteria
Mm-hmm.
that you don't communicate? Well, no, this kid communicate. Maybe they don't do it through language, but they communicate. Or that they have social impairment. Well, no, this kid doesn't have social impairment. This kid is so deeply compassionate and caring and intuitive. You don't always see this in a 5-year-old, but when you have like a 25-year-old, you really begin to appreciate these things.
Oh,
And not only are they, compassionate and empathic and bright, but they are actually the smartest, most empathic kids I've ever met in my life, or people I've ever met. And that's the gift. That's why we do it. And I think so that's the hopeful piece is that you want everybody to get there to see that. And once you see it, you want the whole world to see it. And when you have that negative person, that negatoid who's going to come along and deny it, it's painful. It's painful, but I would say that for every parent, just trust your gut on that. And that maternal instinct is there for a reason. It's never wrong. And you don't need some negatoid to confirm or deny what you already know in your heart. Your life is a lot better if you just follow your path and know your truth and trust it.
yeah.
So I would just leave with that. There's so many smart, compassionate kids out there, and we just want to unlock every one of them.
I love that you're getting more and more spellers in your practice and that you're so supportive of spelling to communicate because it's really exploded over the last few years. And I was in your office and you had a speller there when Allie was there, and it was really cool, that they came in with their letterboard, and it's just really cool. And I love the way that you were talking to our kids because so many people do the baby talk thing with our kids. And I was guilty of it myself for way too long. I did not realize how incredibly smart my daughter was because her doctors that diagnosed her told me, well, she's like developmentally, she's like 7 years old, maybe, you know what I mean? So that I believed that for way too long. But you get it, and you're so respectful to our kids, and that must make them all feel just so good to be heard finally.
I mean, I love my spellers, but maybe a good place to leave this is, and you're gonna have to excuse my French, but it wasn't my language. It was this girl's language. But a speller I know, I've known since she was about 4. Showed her family one day that she actually understands like high level math, and they didn't realize that she had learned this. So the mom asked her, "Did you learn that in school?" And she spelled to her mom. She said, and again, this isn't my language. She said, "All they taught me in school is Mary had a fucking little lamb."
Yeah,
And
yeah,
that sums everything up.
yeah,
She was smart, she was there, she was present, and she was learning Mary Had a Little Lamb for 12 years
right.
or whatever it was, right?
Yeah,
And but yeah, so I think that's what we're that's what we're trying to fight against. That's what we want to, that's why we want to unlock all these kids and show the world, what's inside.
What
And
is really inside. Yeah,
you can't do it if you don't treat the medical. Like you really got to get them medically right to see
right.
it.
And I think, what you're saying about using the words co-occurring medical conditions isn't quite right. I think it's more that autism is a whole body disorder. And we have to find the pieces for each kid. It might be something different. It might be cerebral folate deficiency, the primary driver for one kid. Could be the mitochondrial dysfunction for another. While we're talking about spelling real quick, I'm just going to say that our next webinar will be on March 5th with Dr. Jana Johnson. You know her, right? Dr. G, you
Oh
know
yeah,
him.
yeah.
Dana Johnson will be with us. She's an OT and she's going to be talking about whole body apraxia and how difficult it is for our kids. They just have this brain body disconnect. Like they want their body to do certain things or they don't want their body to do certain things and they have no control over it. So we're going to be talking about that. She is a spelling to communicate practitioner and she's just brilliant. That talk is going to be focusing on the motor skills and the apraxia that our kids are suffering from. So, Dr. Gaitanis, thank you for hanging out with us tonight
Yeah, my pleasure. It was
during
great.
your travels. I really appreciate your time, and it's always so good to talk to you. We just love you. Thanks for everything you're doing for all of our kids.
I appreciate it. Thanks.
All right, everybody, thanks so much for joining us. We'll see you on March 5th. Have a great night.
Take care.